Okay, hello everyone. My name is Carrie Williams. I'm the Director of Operations and Development here at NothingPink. Our home office is The Roots. It's located in Rock Hill, South Carolina, and we serve women across North and South Carolina. Our mission is to create awareness of hereditary breast and gynecological cancer and provide personalized support to individuals at high risk. So today we are thrilled to have Dr. Dallas from Oncology Specialists of Charlotte. Thanks for being here with us, Dr. Dallas.
Thank you.
Yes, and she has over a decade of experience in oncology. She is board certified in medical oncology, hematology, and internal medicine, and also received voted top doctor in 2022 as a medical oncologist by Charlotte Magazine. So today we are talking about so many questions that we have about breast screening. There's so much out there, and Dr. Dallas, I'm so happy you could be with us today to help bring some clarity and understanding to this topic for us. Thanks.
Thank you. Wait, now how did I do this before?
That's okay. So the present now down at the bottom with the little screen and the arrow.
Mm-hmm. So I was going to do entire screen. Oh, and it was this one.
We can see, yeah.
There we go. Perfect.
Okay, sorry about that.
No, you're fine. Okay, Dr. Dallas, thank you for getting us started.
So I had just a few things to go through first, and then I want to answer all the questions. So just briefly, breast cancer, it's important, most common cancer in women in the United States, the second most common cause for cancer deaths in women. The lifetime risk, and I think this is really important for the average woman, is about 12 to 13%. And that's over the lifetime, usually calculated up to age 70 or 80. Screening programs have led to a decrease in the rate of death from breast cancer. Interestingly, the incidence of breast cancer has been going up, but we think that's because of the screening that we're just diagnosing more, but it has led to a decrease in the risk for death from breast cancer. So we said the average risk is 12 to 13%. And there's a lot of things that modify this risk, and some of them are completely outside of our control. Age is one. As we age, our risk for breast cancer does go up. Being female is really the biggest risk factor. Men can develop breast cancer, but it's much more rare. Things like race or ethnicity. There are statistics that show that Black women are more likely to develop breast cancer, and it's more likely to be triple negative, which is a more aggressive form. Um, Obesity, estrogen exposure. So that's, we always ask about how old were you when you started having periods, and then going through menopause, and then, was there any exogenous estrogen exposure, like oral contraceptives and things like that? Oral contraceptives seem to increase the risk while a woman is taking them, and maybe for a year, maybe up to 5 years after, but that risk decreases afterwards. It's a little bit more of a risk with hormone replacement therapy for postmenopausal women. Breast density, which I think is one of the big issues, family history and genetics, and then benign breast disease. So things like atypical ductal hyperplasia, which is something that we find sometimes on biopsy. It's not malignant, but it does indicate that you may have a much higher risk for breast cancer. And then the kind of a specialized situation, the people who've had radiation to the chest for, let's say, Hodgkin lymphoma, especially if they're if they received that when they were younger than 30, that can also increase your risk because breast tissue is developing when you receive that radiation. So we always have to think about things like that as well. Currently, there are a lot of different recommendations for breast cancer screening. This is consistent with what the NCCN recommends, and I think this is what most people follow. We usually like to start screening at age 40 with annual mammograms. There are some guidelines which suggest starting at age 45 or doing every other year mammograms. But most of us usually recommend starting at age 40 annually. There's no good consensus on when we stop doing mammograms. Usually we say if somebody has a good performance status and a life expectancy of 10 years, then that's a good guide to continue. Um, if you have a family history, and this is usually considered to be a first degree relative, we would suggest starting 10 years younger than the relative's age at diagnosis, but not prior to age 30, unless it's a very different situation, and not later than age 40. So if you had a mother or a sister who was diagnosed at age 45, then starting at age 35 um, makes sense. And then for for people who have a calculated high risk, and that's greater than 20% lifetime risk, we do recommend doing MRI and mammograms. And I'll talk more about the high risk. And then the other question we want to answer is, does screening differ for those with dense breast tissue? Um, so we've heard a lot about breast density recently. It's been mandated by the federal government now that the imaging centers have to report breast density. But the problem is that they don't mandate that insurance has to cover any additional screening.
Mm.
The language on the mammograms tends to not make a lot of sense, and so it's been very confusing. Um, Dense breast tissue can be related to a lot of different factors: younger age, estrogen exposure, mostly exogenous estrogen exposure, so like taking oral contraceptives. Some of it's just genetics, and some of it's related to like how many pregnancies and deliveries you've had. Um, the breast density is measured. There's different ways to measure it, but the most common one is this BIRADS classification, and this is done by the radiologist. So there's a little bit of subjectivity, but there's four classifications: A, B, C, and D. Um, A is almost completely fatty, whereas D is extreme breast density. And so C and D are considered to be dense breast. And I think it's important to remember that it's not abnormal. It's actually about 50% of women will fall into category C or D. So it's not an abnormality. A lot of factors go into it, and it can change over time. There are some other ways that you might see, sometimes they see the Volpara measurement, and that's more of an AI computerized type model that can measure maybe a little bit more precisely, and it'll give you a number between 2% and 35%. And so it's on a continuum, so theoretically that would give you some more information. It's not available everywhere, so usually we see the BIRAD is what's reported. The increase in breast density can increase your risk for breast cancer, but it doesn't seem to have any correlation with breast cancer death. So it doesn't indicate risk for a higher grade breast tumor, and it's only one of the components of your risk. And then I think this is helpful to kind of see what it is that we're talking about. So breast density is not something that is seen on the physical exam. It doesn't have anything to do with like the size of the breast or anything like that. It's not something that you can see. So to the far left is the BIRADS breast density A, so that's mostly fatty. And if you look, you can see that if there was something here, we would be able to see it much better than on the extreme breast density, where a small mass could hide. So there are two components to the breast density. Part of it is that it may increase your risk for breast cancer, and then also it may make it harder to see anything on or to see a small mass on mammogram. Um, so another thing that I think is important as a part of your entire risk assessment is genetic testing. And so these are genes that are typically DNA repair genes, but there's other things that are looked at. And so if you think about a DNA repair gene, if it's not repairing your DNA, then we can accumulate, abnormalities, and that can lead to cancer. So BRCA1 and BRCA2 are the genes that we think of the most because we have more information on those. Most breast cancers are not related to one of these abnormal genes, but I think it's always important to think about that and to kind of assess your risk for that. The reason that this one, to BRCA1, for example, carries a lifetime risk for breast cancer of up to 87%. And so that risk is calculated up to age 70. That's a huge risk. BRCA2 is also high risk, but it's not quite as high. They also carry risks for other malignancies. So ovarian cancer being the big one. BRCA1, the risk for ovarian cancer is around 63%. And men can inherit these as well, and that does increase their risk for breast cancer and other cancers, particularly pancreatic, prostate. So when we do the genetic testing, we're not diagnosing cancer, we're just identifying whether you have that gene that puts you at higher risk. Up until about 2013, we were doing just single gene testing. But around 2013, we started to look at these multi-gene panels. So other than BRCA1 or BRCA2, we were looking at PALB2, CHEK2. There's a lot of different genes that can put you at risk for breast cancer and some for other cancers as well. We usually do these with a blood test. You can do a buccal swab where they swab the cheek. And then it's who needs to think about genetic testing? I think this is important. There's a lot of us that believe that we all should have the opportunity for genetic testing, but the people who are at high risk would be somebody who has a family history, especially a close, like a first degree relative, particularly if they have a young age at diagnosis, so younger than age 50. If you see multiple family members on one side of the family with a cancer diagnosis, that should make you think about genetic testing. Um, People who have Ashkenazi Jewish ancestry have a much higher risk of having, there's three particular BRCA mutations. So their risk is actually 1 in 40. So it's much higher than the 1 in 400 in the general population. Another thing that we don't think about as much is if you don't know what your family history is. So some families don't talk about things. Some patients don't know one side of their family or don't know anything about their family history. And that can be a reason also to do genetic testing. Um, Now, if we do the genetic testing and we don't find any BRCA gene or any of the other concerning genes, then I like to do these risk models or predictive models. And so these are computerized algorithms that kind of take into account different things: family history, age at menarche and age at menopause, whether or not you've had biopsies, benign breast disease, things like that. And I usually use the tyrocusic um, model, but there are others that can be used. Um, for this purpose, we need to use one that has more family history than just first degree relatives. So that's why I use the tyrocusic on this one. So it takes into account these things, and it'll give us an estimate of your lifetime risk for breast cancer. So again, the average woman has a 12 to 13% risk. So we use 20% as the high risk mark. And this is important because if you have a higher risk, we can consider doing MRIs and mammograms for screening. And so we would plan usually to do them each once a year, but stagger them by 6 months so that you're getting imaging every 6 months. There are drawbacks to MRI. You may find more lesions than you were expecting, and it may lead to biopsies that are completely normal. Um, there's another model that I use, the GALE model, and this is the National Cancer Institute model, and it takes into account first degree relatives, ethnicity, estrogen exposure, biopsies, and it will give you it gives a lifetime risk, but I don't think that's as accurate because it doesn't take into account all the family history. So we use it for the 5-year risk. So if that risk is 1.7% or greater, we consider chemoprevention. Chemoprevention is not chemo, it's just estrogen blocking therapy, so either tamoxifen or aromatase inhibitors. 1.7% was used because that's what was used in the trial and found to be kind of the break point where it became more meaningful to use these estrogen inhibitors. Gale model cannot be used in people who are younger than age 35. It's just not validated for that. And the trouble with this and all of the risk models is that tend to um, they tend to include more white women than other ethnicities. So it may not be um, as accurate or as helpful in those of different ethnicities.
If I can ask a quick question while we're on the
Yeah.
slide. So, regarding the Tyrer-Cuzick and 20% lifetime risk is considered the high risk category. In your experience, is insurance covering MRI mammography every 6 months if they're over that 20% without a genetic mutation identified?
They usually do. I usually advise people to call their insurance company and find out what their part would be because certainly you can have something that's covered that still leaves you with a really high copay.
Mm-hmm.
But for the most part, we are able to get that covered for most people. Um, there is also an abbreviated MRI, and so I know that Novant was doing that at one point. But an abbreviated MRI takes fewer sequences, but it's still enough to give you information about whether there's any mass. Um, and so it only takes about less than 10 minutes, whereas a normal MRI may take 30, 40 minutes. So it's quicker and it's less costly. So sometimes we offer that as an option if you can't get the MRI covered. But my experience has been that it usually gets covered well. Um, and I usually don't have any problems getting mammograms covered. And I usually stagger them by the 6 months so that you're getting something every 6 months.
Mm-hmm. Okay. And so this level of screening could also be fitting for someone who has a mutation identified in the family, but that individual hasn't done their own genetic testing yet,
Correct.
because they would be in that percentage of
Right.
lifetime risk. Okay.
Right. That would also be an option, like you said, for especially BRCA1 and BRCA2, or even some of the others like a CHEK2 mutation, which is not really known what the risk is. We think it's somewhere between about 23% and 53%. Um, so that's also something where you might want to use this screening pattern.
Right. Okay.
Um, so then these are some of the questions. Does dense breast tissue put me at higher risk?
Mm-hmm.
And the answer is maybe. There are a lot of factors that contribute to a higher risk for breast cancer. So, and we've talked about some of those things. So right now, the recommendation is not to do MRI or ultrasound based only on density. If someone has a high risk and higher density, then that's a reason to do the MRI or ultrasound. But just for breast density, it's not the recommendation. And the reason for that is there have been a lot of studies. Most of them were retrospective, but a lot of studies looking at the findings from those tests. And there's a lot of false positives. So where you find something that requires a biopsy, and then the biopsy is benign. And so in one study, when they used ultrasound to screen people with, just average risk, but extreme or heterogeneously dense breast, they had 90% false positives.
Mm.
So some of the issue is, what is your tolerance for finding something that may require a biopsy? But so right now, the recommendation is not to do ultrasound or MRI for screening just because of breast density.
Okay.
What I would recommend is just having a conversation with your doctor or with an oncologist. And this is what we like to do, and kind of go over all the risk factors and kind of get a better idea of what an individual's risk is, because we're all so different. There's so many differences and so many things that contribute to your risk. So dense breast tissue may figure into that. It is part of the Tyrer-Cuzick score,
Mm-hmm.
but just that by itself isn't a reason to do MRI.
Okay.
And then one of the questions was, if I have a family history of breast cancer, when should I start screening? And I think we had discussed earlier, but usually 10 years younger than the youngest affected relative, usually a first degree relative, preferably not before age 30 and not after age 40. And the reason for that is, well, after age 40, you should be doing mammograms regardless, just for regular screening. Um, Before age 30, the mammogram may not be as useful. You may have increased breast density that makes it difficult to see. And in that situation, if you need to do mammograms before age 30, we usually recommend considering MRIs as well, because that may, in a situation where somebody is that high risk, we may need to do an MRI to get a better image. And, for all of these things, these are just screening recommendations. So it's completely different if you have a diagnosis or if there's an abnormal finding on mammogram that we have to look further. So this is just screening recommendations. So what other screening modalities are available or recommended? I mentioned the abbreviated MRI, which is a good choice for somebody who either can't tolerate the regular MRI, because it does take 30-40 minutes to do, or they can't get it covered, or can't get it paid for by the insurance. So those are options. And then this is something that I hear a lot. Some people want to try thermography. And so thermography was something that was developed in the 70s, and it's been updated, but the theory is that you have a higher skin temperature overlying a breast cancer.
Mm-hmm.
And in theory, it sounds nice, but the problem is it has a high false positive rate, and the false negative rate in some series were suggested to be about 60%. That's missing 60% of masses is very concerning to me. So it's not recommended by any of the cancer or breast cancer societies. There is one device that's actually FDA approved, but it was approved because it's not dangerous. It's safe. It's infrared. They use infrared technology for that, but it's not efficacious. It doesn't really give us good responses. So that's something I hear questioned a lot.
Yes. Yes, definitely. I think there's been a lot of marketing and promotion around, and I think all of us would be happy to, hear of another option besides mammography because it's uncomfortable. So yes, we get a lot of questions about that too. So Rachel has a question too. Go ahead, Rachel. Oh, let's see. Are you there, Rachel? Okay, maybe she'll come back with that. Go ahead, Dr. Dallas. Thank you.
Well, this is my last slide. In general, I feel like everybody deserves to have the chance to sit down and talk with somebody about their breast cancer risk, whether or not they need genetic testing or mammograms with MRIs. And so we do have a high risk breast cancer program within our practice. And so we can do genetic screening. We can help, walk through and calculate the risk and give the options. I'm part of that as well as my partner, Dr. O'Keefe. These are the two offices, and then this is our phone number if you want to schedule. If anybody wants to schedule an appointment so that we can go through those things.
Yeah.
It's such a complicated issue. There's not just one answer for everybody.
Thank you so much. And I'll also add to that it's always a great idea to get a second opinion. So even if your doctor has made a guideline or suggestions for you, that maybe you want to speak with someone else to get affirmation that you're on a good screening path, or maybe that there are other options or other screenings that you should be getting in addition to what was previously recommended. So thank you very much, Dr. Dallas, for that. Very informative. And I think Rachel is back. Let me see if she's got her microphone on. Did you want to go ahead with your question, Rachel? Okay, we can't hear you. I don't know if you have your microphone on. I wonder if it's... let's see here. Okay, Rachel said that she is curious about contrast-aided mammography.
So that is another option. Usually, if you can't get the MRI for whatever reason, if there's an issue with the gadolinium, or if you're just unable to have that done. But that is a recommendation for those at higher risk. I would have to say that I've not seen that done. So I don't know if that's something that we can do in the area. I would imagine it could be done.
Okay, wonderful. All right. Well, thank you so much, Dr. Dallas. We'll stay on the call. I'll just finish the recording here.
Okay.